And I'd like to introduce Dr. Eric Luck, who is the Director of Critical Care Services at Swedish Common Hospital in Chicago and Professor of Medicine at Fisk University, Chicago Medical School.
These are my disclosures. Not very much there. I give talks about my research, which is pretty much almost now only on Procalcitonin. Anyhow, I want to talk about some historical stuff and some pathophysiology so we can understand why a marker that is supposed to be used for lowering calcium levels has anything whatsoever to do with infection, and why we need a marker like that to identify infections in our patients. Anyhow, if you go back to when I was a house officer, diagnosis of infection was pretty much a gut feeling. Yeah, how do you know the guy's infected? Well, I know the guy's infected. In fact, sadly, about 5 or 6 years ago at one of these symposiums, a young critical care doc was telling me he didn't need a biomarker, and I said, well, why not? He says, well, I know when the guy's infected. And I said, well, how do you know? He says, I just know. Okay, I don't know. I've been doing it a lot longer than he, and I still don't know. So anyhow, if we also look, antibiotics have been prescribed and not titrated, and I think that's a silly thing. Why would we give the same dose of antibiotics for the same duration as when people present with a syndrome of infections, from somebody who's just been sick for a day or two, or to somebody who's been sick for 3 or 4 days? So it's different, and antibiotics need to be titrated, probably in the same manner that other drugs are titrated. Regimens are typically based on duration and not on an individual's response. And I'm not exactly sure even how these regimen durations were established. I inherited them when I was a house officer. How long do I treat this? Well, 7 days. Why? 7 days. That's what we do. This one's 10, this one's 14, and I spent hours and hours and hours memorizing this so that on rounds when I got pimped, I would know exactly how many days to treat the infection for. But I think that we have moved beyond that, and we need to start thinking about infection on an individual patient. We need to understand the immunocompetency of the patient, how long the patient's been ill before the presentation, what the organism actually is, because organisms have their own doubling time and their own virulence factors. We need to know what the bacterial burden is. We need to know the site of infection, because certainly different sites of infection will portend different kinds of reactions by the patient. And of course, we need to understand the patient, and two of the most important factors are the nutritional status and the patient's functional status. Actually, possibly even the most recent medical history on this patient. So how do you know when there's an infection? If you notice, the SIRS criteria for sepsis and the new criteria, we'll show you them side by side in a second, they don't tell you how to identify when there is an infection. They just tell you how to classify infections into different categories, most recent based on mortality data. They don't tell you when there is an infection. Well, so when is there an infection? Well, an infection is when the body thinks there's an infection. I mean, we have 5 trillion, that's what all those zeros are. We have 5 trillion bacteria in our body, and they're playing nice with us. And as long as they do that, that's not an infection. But you'll see on a couple of slides from now that those organisms that are our friends sometimes can turn on us. And in fact, most infections are internal infections. So that is a very significant thing. They are essential for our survival, and this is a mutually beneficial thing. So infections can come from outside and inside, but the only way we're really going to know that there is an infection is when the body sees a threat and makes a response. And we need a specific response, not just a generalized response. So then the duration of the antibiotic therapy should be dictated by the response to treatment. Some patients will respond more rapidly than others, and we can shorten their course. Other patients need a couple extra days, need to lengthen their course of bacterial treatment, antimicrobial therapy, because otherwise they'll get recurrent infections, and possibly that's one of the reasons we still see recurrent infections. We also know that white cells and other macro markers like temperature, fever, respiratory rate, they're not very specific. 2/3 of the patients in an ICU meet the SIRS criteria, but only 1/4 of the patients have sepsis, typically. So how does the body know that there's an infection? Well, we've been fighting infections for millions and millions, well, actually hundreds of millions of years, and we have a surveillance system. All our cells have on them these receptors, the TLRs. I can't use the pointer very well. And basically, they're sort of like antennae, and they're looking into our extracellular fluid and looking for pathogens, things that could do us harm. And there's other things besides organisms that can do us harm. Damage to other cells can do us harm. So those are the two different responses. And these receptors, and there's 12 of them, you don't need to remember that, but the beauty of the 12 of them is that they can actually identify every single microorganism that can attack us relatively specifically, differentiate between fungi, bacteria, protozoa, and viruses, and make a response appropriate to what's attacking us. Now, we have bacteria throughout our body, and most of those bacteria are just in a symbiotic relationship with us. Now, as soon as you get into the ICU, we introduce a whole bunch of new bacteria. Those are colonized, and they're not going to necessarily do us any harm. They can, but right now they're just hanging out, doing their thing, and not interfering with us. Some of these bacteria, though, can create problems, as you can see along that curve. If we damage the mucosal surface, these bacteria that were not problematic now can cause an infection. We also do see those pathogens that are virulent, and they can do whatever they want as far as causing infection without worrying about whether the host has been damaged or not. There is a dose-response curve. Our surveillance system is looking around, and it will make a signal specifically dependent on the degree of danger that it sees. If there's just some fractions of bacteria cell walls in the neighborhood, a small response will be seen. If we see dead bacteria, a more significant response. If we see large numbers of living bacteria that are not our friends, there'll be a more significant response. And then finally, when we have virulent organisms, there'll be a very vigorous response. And that's what's depicted on this curve. As you can see, that dose-response curve goes up from left to right, and the response of the organism goes up significantly from left to right as well. Now, how do we respond to these things? Well, these toll receptors will respond to what are called pathogen-associated metabolic patterns. Basically, they recognize parts of the cell wall, parts of the innards of these bacteria, and they will then create a response. These are called PAMPs. If there is another kind of injury, like damage to the cells, then the stuff that's inside the cells leaks out, and there's a different response. And this is called DAMPs, damage-associated metabolic patterns. And they're different. The types of cells and the response that we need to get for them are quite specific. The problem is that when you get a bacterial infection, you can damage your cells as well. And so it is possible for the body to misread this signal. Now, if you misread a damaged signal and it takes you a little while to clear up the inflammation, that's not as big a deal as if you miss a pathogen signal, because these pathogens are doubling every 6 to 12 minutes. And missing that signal for even an hour or so can create a tremendous problem. So that's what's depicted on this, the signals from the PAMPs and DAMPs. Now, I call this response the firefighter response in the body. When you call 911 and there's a fire, the person on the other end of the phone doesn't ask you, is it a big fire, is it a small fire, is it a wood fire, is it an oil fire? It just sends the fire company. They'll sort it out once they get there, because they don't want to get there shorthanded. Well, it turns out the body does exactly the same thing. Well, it could be damp response, could be just damage, could be a pathogen, really not sure. Well, let's assume that it's damage, and now the organism's under duress because of this infection that's taking place. So what does it do? It responds exactly the same whether you have sterile inflammation or whether you have bacterial inflammation initially. And that's why, as a clinician, you can't tell by looking at the patient. They will have a fever. They will have a white coat. They will have tachycardia. They will have tachypnea. All those criteria are not specific for infection. They are specific for the production of these cytokines that are depicted in this, especially IL-1. That is the 911 call. We got a problem here. And that signal will be dependent on how big that problem is, how much that cell is stimulated, and how many of the other cells. As it turns out, procalcitonin is one of those signalers. It's basically saying, I'm a cell over here, I've been stimulated, I'll make some procalcitonin, it will get leaked out of the cells, it'll go to the cells a few millimeters away and say, oh, well, there's trouble in the neighborhood. They'll turn on their signals so that they can start fighting the infection and so on and so forth. So it turns out, it looks like it's a signaling device. And this is what it looks like. The right, all the way to the right is the damp signal, all the way to the left are the multiple different bacterial signals. But if you follow the lines pretty carefully, you'll see that they both end up in IL-1 secretion. And that's why the markers that we had used are not specific enough for us to identify infectious risk. And that's why we're looking for biomarkers that are part of the intrinsic pattern of response of the cells. PCT, C-reactive protein are biomarkers that do that. There'll be more specific biomarkers probably in the future, but right now, these are the two that we can work with. IL-1, TNF, and IL-6 that we talked about already are markers that will go up in infections, but they are not specific to infections. So to summarize, the innate immune system can't differentiate sepsis from damage. It doesn't want to. As that process keeps going on, and it becomes more clear that most of the stimulation is coming from damaged cells, then the signal will change and the body will turn into a system for clearing debris. If the stimulation comes from the bacteria increases, then those receptors will make that response much more specific. So basically, I've been using PCT for about 8 years. We do about 200 levels every month. I wouldn't keep doing that if I didn't think they were very, very useful. We've developed many different algorithms for it. One of my favorites is that if we get two negative PCTs 24 hours apart, my pharmacist will come and start screaming at you to stop antibiotics. Some data that we had collected showed us that we were also able to identify prognosis that, as Dr. Nate pointed out, procalcitonin levels go up and then they decline with a wonderful half-life of about 50% every 24 hours. When a patient's levels do not decline at that rate, the prognosis for that patient is significantly poorer. So someone whose levels have declined by 80% over the first 72 hours has a mortality rate from severe sepsis or septic shock of only about 11%. If their levels do not decline by 80% over those 72 hours, the mortality rate is 3 times higher, 33%. And that's what these data that was published in Critical Care demonstrate. I promised you that we'd see a side-by-side matchup of the old and new sepsis criteria. There's really not a whole lot of difference there. And again, these criteria don't tell you if there's an infection present. You have to figure out if there's an infection present. And some of those criteria that we're throwing out, the service criteria, are still to some degree useful. But we are looking each day for things that are much more specific. And of course, to differentiate infection from sepsis, you need the SOFA score, so I just figured I'd show it. Dr. Nate already showed you that slide. This is a receiver-operated curve demonstrating the efficacy of the different biomarkers. We compared PCT, C-reactive protein, IL-6, and lactate. Lactate got a bum deal here because lactate is a biomarker for sepsis, but it's not really specific for sepsis. It is specific for perfusion, and it will go up in sepsis if there's hypoperfusion. It will not go up in sepsis if there's no hypoperfusion. It will go up in non-infectious diseases when there's hypoperfusion, like cardiogenic shock. And it will not necessarily mean that there's an infection. So 2 different markers, which add different pieces of information to your understanding and taking care of the patient at the bedside. So those are my introduction. Now I'm going to show you some cases. They're not glitzy cases. These are just cases that came right out of my ICU over the last 6 months. And I update them every once in a while. These cases I specifically chose to demonstrate the utility of both lactate and procalcitonin simultaneously in patients. So we have our first patient, nausea, vomiting, abdominal pain, liver function tests were abnormal, white count was elevated, not much of a left shift, lipase was normal, prevailing diagnosis amongst my clinician friends was ascending cholangitis. So patient was initially resuscitated, probably in our emergency department, 3 liters of normal saline. That was before we changed to 30 mLs per kilogram, so that's a little bit old. Antibiotics were started. We're all under the gun. We need to get the antibiotics into the patient within 3 hours. Antibiotics were started. Cultures were obtained. So we're meeting all our CMS guidelines. And now we're going to look at some biomarker evaluations. For the next bunch of cases, lactate will be in blue, procalcitonin will be in red, and I did my best to use the axes to make this clear. If you look at the bottom, you'll see 0.25 and 0.5, that's days. So day 0 is when the patient presented, 0.25 was a quarter of a day, 6 hours, and 0.5 was 12 hours. This is the only one that has that. Anyhow, when the patient presented, the lactate level was elevated, and in fact, the procalcitonin level was not. However, with resuscitation over the first 6 to 12 hours, the lactate level starts coming down. We typically don't repeat the PCT for 12 to 24 hours, usually about 24 hours. And you can see our resuscitation was successful in that the lactate levels returned to normal. They bounce around for a little bit, but now you can see the procalcitonin levels at the top. The level at 24 hours increased from 0.2 all the way up to 10.7. And this is the pattern that you'll see about 30% of the time. Patients will present with a negative PCT that becomes positive within 24 hours. The rest of the time, the patient will present with a positive PCT initially. With 24 hours of antibiotics on board, the PCT levels remained about the same. The lactate level is still low, but now we see our antimicrobial response. We see the decline in procalcitonin, which approximates about 50% in a patient who's responding. Might be a little bit slower in patients with renal failure, so you have to be aware of that. And then this is the classical response. Now, as it turns out, when that level reaches 0.4, 2 very large randomized studies shown that you could stop antibiotics right then and there with no risk for reinfection. So this is a patient with ascending cholangitis who theoretically needed only 6 days of antibiotics. But the patient would have gotten, on the most regimens, somewhere between 7 and 14 days of antibiotics. So the patient did quite well and lived happily ever after. So we'll go to case number 2. This was in this case, and we have 2 scenarios because these 2 patients presented within 6 hours of themselves and really became very useful for teaching purposes. So this was a woman who presented with shortness of breath. She was hypoxic. She had bilateral patchy infiltrates on a chest x-ray. There was a white count that was elevated, left shift. There was some argument, is this infection? Is this just the patient's stress? Because she had watery yellows, tinged sputum, no subjective fevers, and people were wondering heart failure or pneumonia and heart failure. So that was our differential. And so now we get our biomarkers, and the initial one shows an elevated lactate. Okay, so hypoperfusion is present. Could be sepsis, could be heart failure. The initial PCT is negative, but that first PCT sometimes can be negative. This patient received a day of antibiotics. Now what happens? On the next day, the lactate level is actually going up because everyone was sort of leaning in this situation to infection, and they weren't treating aggressively or heart failure. PCTs are negative. We are now convinced the patient does not have a bacterial infection. The patient was placed on dobutamine and some afterload reducing agents, some non-invasive positive pressure ventilation for afterload reduction, and her lactate level did respond to all those interventions, which were all cardiac. The antibiotics were stopped. Contrast that to this patient, almost exactly the same presentation, shortness of breath for a period of a day or 2. And in this situation, the patient's initial procalcitonin was low and not very significant. The lactate level was almost exactly the same. but now look what happens. Here the PCT goes up to 3.8, clearly significantly increased and consistent with a bacterial infection. The lactate levels declined with fluid administration, and this patient basically had a very nice clinical recovery from sepsis. The x-rays look almost identical. The patient's history and clinical presentation were almost identical. The only difference was the interactions of the biomarkers. In the first case, the PCT was negative for 24 hours, and in this case, the PCT increased. Okay, this is another patient with a 2-day history of diarrhea and some fever to 102. A patient had recently undergone a revision of her hip, and she received 48 hours of prophylactic antibiotics. Okay, and that was about, if I'm not mistaken, 5 or 6 days before she was admitted. In the ED, these were her numbers. She had 14% bands. White count was actually in our hospital was still within normal limits, but she did have tachycardia and an elevated temperature. Her abdomen was a bit distended. She was tended diffusely. Her bowel sounds were hyperactive. This seemed to be an antibiotic-related diarrhea, probably C. diff, which was kind of sad because she really did require prophylactic antibiotics for the hip, and it was only 2 days. Anyhow, you can see there, well, not very easily because I changed the scale on you. Her PCT level is 15.8 on presentation. It was quite elevated. Went up to 89, but with appropriate therapy, it starts to come down. And notice the lactate, and not so easy to notice the lactate, never became elevated. Now, this patient was extremely ill, and clearly septic, but this was a patient who did not have problems with hypoperfusion, and her lactate level never was elevated. So lactate levels aren't always elevated, even in patients with severe sepsis. Okay, and then she had a very, very nice response until day 7. And you notice between day 6 and day 7, the PCT levels are now going back up, and they went really, really high. And she actually had perforated colon and ended up going into septic shock, and the levels continued to go up, and she expired. Very sorry, very sad case. So when the PCT levels start coming down in a patient who's adequately treated, they will continue to go down to normal. If they stop going down or if they start going up, it is a sign that infection is not being controlled. Okay. Yes, still good. Okay. Case number 4, we have a patient with frequency of dysuria, positive leukocyte esterase, nitrites, white cells, a lot of bacteria. Initial presentation shows an elevated lactate and an elevated PCT. So this is probably more than urosepsis. This may be pyelonephritis. Ultrasound basically suggested that was a possibility. You can see with fluid resuscitation, once again, the lactate level goes down. PCT barely budged, though, just went down a little bit. And in fact, over those now 48 hours that the patient's in the hospital, there's really not been a positive trend. And in fact, it's actually going up, despite the fact that the perfusion of this patient is still being adequately maintained. So an ultrasound was done, and the patient ended up having an abscess in her kidney, perinephric abscess rather, and it was drained by IR. The patient was placed on additional antibiotics because we never had a positive culture from the urine nor any other sample in the blood. And then, I just to shorten the case, this was her post abscess drainage course. You can see the lactate, we stopped ordering them because they were always normal. And you can see the procalcitonin now declining very nicely after the drainage. So you can see it was going up, or you argue that maybe the numbers aren't really all that different, but certainly not coming down. But then after drainage and source control of the infection, a nice decline.